So what do we do about these three ideas, or these three experiments? How do they come together? Well, in my mind, what they're doing is they're constructing a framework for how people can engage with their health. So we can make ourselves into an experiment. We can start paying attention to what we're doing and monitoring what we're doing actively, like they have done in the National Weight Control Registry. And we can start to seize the sense of control that turned up in Whitehall Street. We can put these together into what is actually a pretty big idea, that the more we pay attention to our health, the better our health will be. And other research has shown that this is true. This is a fact that has been demonstrated not just in these three studies, but actually a lot of research. When you can engage people in their health, they have better health. And it becomes a catalyst for all these other behaviors that we want people to do and things that we want people to engage in. Mindfulness matters. Mindfulness, in some ways, is the most important health decision we can make. So that's where the idea comes from. And then I want to just talk a little bit about where the idea goes. So it's important to think about, or to realize that this is actually in contrast to the way we get a lot of health information. Most health information comes at us in a barrage of do's and don'ts. It is this cascade, this kind of tumult of things that we're doing and we're probably doing wrong. We do not have control in this scenario. We are not the people that are making the decisions. We are not the drivers of the path. There are some exceptions. There are some areas where we actually, it is recognized that getting people involved in their care helps. And this is a food diary. And food diaries are known to be an effective way of helping people lose weight. Get them to write down everything that they eat every time. But the trick with food diary and actually self-monitoring as it's been practiced so far is that it actually is asking for people to do another behavior on top of the behavior that they're supposed to be changing. So it's in some ways compounding the compliance problem in pharma terms. You're really asking people to do something else in addition to what they're supposed to be doing, and it becomes that much more complicated. And so there have been other attempts to actually get people engaged in their healthcare and to use perhaps technology as a solution. In the 1960s, there's a pioneer of patient empowerment named Warner Slack at the University of Wisconsin. And I've suggested to Kevin that he get Warner Slack here next year because he came up with the idea of patient power in the 1960s. In fact, he programmed a computer, which is what we see here, to do the medical intake interview, to push the doctor to the side and connect the patient immediately up with a computer, and to get the computer to ask all the questions of kind of what are the health background. And the patient was hooked up to a heart rate monitor. So as the patient would answer questions, the machine was able to monitor what their heart rate was in response to the questions and would tailor the questions accordingly. So it was a way to integrate the feedback and the metrics from the patient into the medical process. And this is what the screen looked like. So the questions were pretty straightforward. Have you ever had an allergic reaction to a penicillin? And depending how the patient might answer this question, it would then, and depending what their heart rate was, it would then tailor to the next question. The trick was that screen is that little square in the middle there. So when you think about it, this does not scale. This is in Jason's terms, this is not a disruptive technology quite yet. So there's a long way to go. But this does scale. This is this is my iPhone, actually, which I have loaded up with all sorts of apps which lets us track all sorts of things about our health. We can track our insulin if we have diabetes. We can track our blood glucose level. We can track our weight. We can track our cigarette consumption if we want to do some smoking cessation. There are dozens and, in fact, hundreds of trackers now available on the iPhone. And these are simple ways to put what we know works via the National Weight Control Registry and other experiments into effect. Now, it may not even be the case that the people developing these apps have any idea that it's based in science, right? They may not have any idea that there are decades of public health research that support these ideas. All they know is that people like it, people like to keep track of things, and it works. Another little gizmo that kind of harkens to this new opportunity for self-tracking is this thing. It's called a Fitbit. And it's a little $99 tool. I have one, but I just lost it, so I couldn't show it to you. It's so small you can lose it. But it tracks your cadence, it tracks your calories, and you can wear it at night, and it tracks your sleep patterns. And it's a very simple way to get some basic biometrics, some basic information about our health, and then to integrate that into our lives. And so when you think about it, something like the iTunes apps, the things that we can put on our iPhone, the Fitbit, the Nike Plus tracking system, which some of you may use to jog, all of these are ways that we can engage with our health, track what we're doing, make ourselves the experiment, and get better results. But what we need, actually, is a system. We need to actually think of this as an overall structure that we can use. It's not enough, probably, just to have incidental tools here or there. So this is where I got the idea for a decision tree, that actually a decision tree is probably the best structure that we may have conceptually to think about how this works. So when you think about a decision tree, it's really just a framework for parsing our own information. It's an algorithm for health, really. It's a way to integrate information about what we're supposed to be doing and what we might have concerns about, what might be family risk factors, things that we could be adjusting, and guiding our lives accordingly. It's really an algorithm for mindfulness, if you think of it that way. It's a way that we can be conscious of what our health is and drive our actions accordingly. And again, just by thinking along these lines, we're already on the road to better outcomes. So I want to give one last example of how this works in practice. There was another study that was done in London, Ontario. And it had a big set of people with high blood pressure, hypertension. And they gave one set of patients home blood pressure monitors, so simple little cuffs that you put on, and told them to monitor their blood pressure at home. And they also gave them a simple decision tree of instructions, which basically boiled down to if their blood pressure was going up, they should take more medication. And if their blood pressure was ticking down, they should take less medication. But it was a simple algorithm that the patients were supposed to follow. And then the other group was just told to go and visit their doctor as usual. And that, of course, is considered the gold standard for hypertensive treatment. Now, after just 2 months, there was already a significant difference between the people who were monitoring their blood pressure at home with their decision tree versus the people who were going to the doctor's office. The people who were monitoring their blood pressure at home had reduced their blood pressure. The people who were going to the doctor's office had actually seen it tick slightly higher. So these principles are actually not just something that work for behavior modification and preventive medicine, but they also work in treatment environments. And so this is really what I kind of want to leave you with, is this idea that it's very powerful. It's not just a kind of good business opportunity or a kind of way to kind of tap technology, get people involved and feel better about their care. The idea of getting people involved in their care is really potentially the best idea for healthcare that we've come around with in a long time. And when you think about it, it makes sense. Life, in many ways, is an experiment, right? I mean, when we think about all the things that we do, how we eat, and whether we get enough exercise, these are all variables that we have some control over, but we are never really sure whether we're doing the right thing. And the opportunity is to actually minimize the uncertainty in this experiment of our lives, and to maximize the opportunity for control, to really try to leverage what we might be able to draw out of the Whitehall studies, or might be able to draw out of the dental clinic in Kansas City, and to put it in effect to improve our lives. And this is really what personalized medicine is all about. It's integrating ourselves into the equation. It's making ourselves the focus and using our own metrics and our own information to drive to better results. So that's the idea. That's the decision tree. And as Kevin said, you'll all get the book and be able to read the full thing in a few months. Thanks very much.